Welcome everyone, and thank you for taking the time to listen and watch our debate. I would like to start by introducing everyone in the group and what our roles and jobs are throughout the debate. My name is Jessie, and I'm introducing the debate, and I will also introduce and talk about our pro side of the argument, which is ABA. Angela is the summarizer for the pros. Mandy is the summarizer for the cons. Katie is the researcher for both sides, and Mandy is the summarizer, and Christina is the illustrator for both sides. And finally, Adrian is the fielder and will answer questions at the end. Applied behavior analysis is an intensive therapy that has been proven to show functional improvements that last in individuals with autism spectrum disorder. For this reason, ABA is considered the gold standard of treatment for individuals with ASD in most of North America. There have been several long-term and large-scale studies done that show that children who receive at least 25 hours of ABA therapy a week for 1 year will make tremendous gains. Some participants even achieve functioning within average range for their age. ABA programs that are used for individuals with autism are supported by a significant amount of scientific evidence. However, even though ABA has years of empirical evidence, some occupational therapists, parents, teachers, and others favor alternative approaches like sensory integration and the medical model. We will be debating why ABA is better than the alternative models of sensory integration and the medical model. Our debate is informal, and here's how it will work. We will start with the medical model. Angela, the summarizer, will explain the pros of the medical model. Then Katie, the researcher, will give some research behind the pros, followed by Christina with illustrations. Once the pro side of the medical model is complete, Mandy will step in with negatives or the con side of the medical model and why ABA is the better option. Katie, the researcher, and Christina, the illustrator, will also add some points against the medical model. Once the medical model is complete, we will follow the exact same format for the sensory integration method. I hope this helps you follow along during our debate. We will again introduce ourselves and our roles as we go so you can follow along. I will now turn it over to Angela, who will begin the debate with the pros of the medical model.
The medical model holds that mental illness is a psychiatric disease with a physical explanation and therefore can use medical treatment. This model views behavioral abnormalities in the same framework as a physical disease or abnormality. Essentially, it treats mental disorders in the same way that something with a known physical cause would be treated, such as a broken arm. Supporters of this model consider symptoms to be outward signs of inner physical disorder. With this, it is believed that these symptoms can be classified into a syndrome, then the true underlying cause can be determined and appropriate physical treatments can be delivered. Addresses symptoms of autism through the use of medication or medical treatments. Medication is often recommended to decrease symptoms of comorbid disorders such as anxiety or depression, especially when behavioral therapies are not showing results. Medication can be easy to use, convenient, and show improvement of behaviors and skills quickly. It has been shown to improve social skills, increase focus level, and retain impulsivity, among other characteristics that are known to be a common trait in autism spectrum disorder. And now Katie will present the research behind the medical model.
The first article that supports the medical model as an effective treatment for symptoms of autism is Antipsychotics in the Treatment of Autism by Posey et al. The article discusses the use of atypical antipsychotics frequently used to treat symptoms of autism, such as irritability, aggression, self-injury, hyperactivity, and stereotypical behavior. The first antipsychotic discussed was risperidone. In one of the studies reviewed, risperidone was successful in improving behavior in 8 out of 14 adults with autism or PDD, according to the Clinical Global Impression Improvement Scale, whereas the placebo group did not see any improvements in behavior. A pediatric study conducted by the research units on Pediatric Psychopharmacology Autism Network was also reviewed. This study had 101 children and adolescent participants with a mean age of 8.8 years. The subjects were rated according to the aberrant behavior checklist, and all showed a significant level of problem behaviors at baseline. The subjects were randomly assigned to a group and either received a placebo or risperidone for 8 weeks. 69% of the subjects receiving risperidone were considered treatment responders, and only 12% of the placebo group responded with a decrease in problem behaviors. Several other studies conducted using risperidone showed improvement in the symptoms of autism. These studies resulted in the FDA approval of the use of risperidone for individuals with autism ages 5 to 16 to treat irritability. Posey et al. Also reviewed the use of olanzapine to treat symptoms of autism and PDD. In one 12-week study, the use of olanzapine in children, adolescents, and adults showed a significant improvement in hyperactivity, social relatedness, sensory responses, language, self-injury, aggression, irritability, and anxiety and depression, according to results from the CGII. Ziprasidone was also reviewed, and in one study showed improvement in behaviors of 6 out of 10 of the participants, and all 10 participants lost an average of 9.5 pounds over the 6-month study. Posey et al. Listed the limitations of their study, including the need for more studies to be conducted on the use of risperidone and other antipsychotics in less irritable children with autism. Risperidone was the only drug that proved to be consistently effective in the treatment of disruptive behaviors, so further studies on other antipsychotics need to be conducted. Additionally, further research must be done on the side effects of this medication. Christina will now present the visuals from this article.
The first visual was taken from the article by Posey et al., and it details the amount of medication, what medication, and what improvements and side effects were seen in each of the studies reviewed. Risperidone was the most commonly reviewed medication, and users saw an improvement in aggression, irritability, repetitive behavior, hyperactivity, communication, and social withdrawal across the studies. The study reviewing olanzapine saw a global improvement from participants, and quetiapine was shown to decrease aggression, hyperactivity, and inattention. Ziprasidone and aripiprazole were both shown to improve aggression and irritability.
The second article that supports the case for the medical model to treat autism spectrum disorders is the treatment of autism with low-dose phenytoin, a case report by Philip D. Bird. This study was conducted with a 19-year-old male as the patient who presented with ADHD and autism. The participant had a history of irritability, impulsivity, aggression, and difficulty with social relationships. Once he had been administered the phenytoin, within 10 minutes he reported that it was easier for him to converse with others and maintain eye contact. Over the course of the next 2 weeks, the subject's family reported that social interaction had increased and there had been no aggressive outbursts. Eventually, after the patient had been taking the phenytoin for 18 months, it was reported that he had developed peer-appropriate relationships for the first time, and his violent outbursts had gone away. The author suggested that further studies with more participants be done to see if this carries over to larger populations. Although this was just a single case study, it does show that medicine may be effective in treating symptoms of autism, including social deficits.
The graph from this article shows the participant scores on the Depression Anxiety Stress Scale and the Autism Spectrum Quotient before and after the use of phenytoin. As shown, his depression score dropped from 25 to near 0, which is well below the clinically significant cutoff of 12. His anxiety score also dropped below the clinically significant cutoff of 14. While his stress score did remain above the clinically significant cutoff, it decreased dramatically after the use of phenytoin. Additionally, his AQ score dropped from 41 to 27, which means it's significant because a score of 32 or more means the subject shows clinically significant autistic traits. So he ended below that level due to the medication.
The final article I will discuss related to the pros of the medical model is hyperbaric oxygen treatment in autism spectrum disorders by Rossignol et al. The article discusses the use of hyperbaric oxygen treatment, which has patients inhale 100% oxygen while in a pressurized chamber. Hyperbaric oxygen treatment can be used to help with physiological abnormalities such as cerebral hypofusion, inflammation, mitochondrial dysfunction, and oxidative stress. Previous studies had shown that this treatment may improve mood, behavior, and social interactions in individuals with autism. This article reviewed several of these studies, and many have shown improvements in sensory problems, aggression, tantruming, and gastrointestinal problems. In one study, 69 children with autism spectrum disorder participated. 33 of the participants received hyperbaric oxygen treatment for 40 sessions over the course of 4 weeks, while the other 29 participants acted as the control group. According to the CGI scale, and the parent-rated CGI scale and ATEC scales, significant improvement in overall functioning, receptive language, social interaction, and sensory awareness were reported for the group receiving hyperbaric oxygen treatments. Christina will now present 3 illustrations from this article.
Okay. These are the charts from the article that reviewed the hyperbaric oxygenation as a form of treatment for individuals with autism. The visual on the far left is coloring pages completed by a 17-year-old with autism before and after the hyperbaric oxygen treatments. The picture on the top left of that picture is before beginning treatment. On the top right is 1 week or 5 sessions of treatment. The bottom left picture is after 3 weeks or 15 hours of treatment, and the bottom right is after 5 weeks of hyperbaric oxygen treatment. The footnote on the visual notes that the individual's coloring skills remain stable after 6 months. This participant also showed an improvement in speech skills as well as self-help skills over the course of the study. The second visual from this article shows handwriting from a 6-year-old boy before and after 41-hour hyperbaric oxygen treatment sessions. His handwriting is more clear and precise after the introduction of hyperbaric oxygenation as a treatment. The final visual from this article is a PET scan image from a 12-year-old boy with autism. These scans were taken before and after 80 hyperbaric oxygen treatment sessions. The white arrows point out the improvement in deeper cortical hypoperfusion patterns. Red shows the midline cerebellum hyperperfusion improvements, and yellow shows the temporal lobe hypoperfusion improvements after the hyperbaric oxygen treatments. Mandy will now explain the cons of the medical model.
Although medication may show an improvement in behaviors and skills, there are a number of cons related to this method of treatment. Medication can come with a variety of side effects, anywhere from mild to debilitating, which can make for an even lesser quality of life for the individuals taking the medication. Additionally, medical treatments can be easily discontinued by parents or the individuals taking the medication. Katie will now take over with the research behind the cons.
One of the most significant cons related to the treatment of autistic symptoms with medicine is the side effects caused by medicine. In the article referenced earlier, Antipsychotics in the Treatment of Autism by Posey et al., many side effects were discussed. One of the studies indicated that risperidone caused at least one aversive side effect in 13 of the 15 subjects that participated in the study. Additionally, in the study conducted by the Research Units on Pediatric Psychopharmacology Autism Network, the subjects receiving risperidone gained an average of almost 6 pounds over the course of the 8-week trial, and an increase in drooling was reported in some of the subjects. Additionally, a study conducted on quetiapine began with 6 subjects, 4 of which dropped out of the study due to poor tolerance of the drug. Of the 2 participants that completed the study, both showed appetite and weight gain. Posey et al. Listed weight gain as the most significant side effect of the use of antipsychotics to treat symptoms of autism because, especially in children and adults, it was noted that weight gain is a concern because it can lead to other medical problems later in life. Other side effects were also discussed, which Christina will address with the visual.
While the pros of this debate mentioned in the improved symptoms as a result of medication use, it is also important to discuss the side effects. The studies reviewing risperidone noted sedation, weight gain, and hypersalivation as the most notable side effects. Olanzapine also caused sedation and weight gain. Quetiapine caused those side effects as well, while also noting increased agitation as a side effect. One study using quetiapine actually had a participant show increased aggression as a result of taking the drug. Ziprasidone and aripiprazole also caused weight gain in their participants. Katie?
Another evident concern related to using medication to treat autism is the fact that medication can be discontinued by the parent, family, or pharmacy. In the study done by Bird, the 19-year-old patient discontinued the use of his medicine after 4 weeks and stayed off of it for 9 months. His behaviors returned to baseline levels of aggression and difficulties in social interaction. Additionally, at the start of the study, additional medication was recommended to help with his aggressive outbursts, but he denied the suggestion, saying that he did not care if he upset others with his behavior. The use of medication can be very unstable depending on the users and their families, as well as their circumstances. Inconsistent use of medication makes it a difficult treatment to maintain. Another negative of medicine in the treatment of autism is that it is not able to significantly impact social skills or language in individuals with autism, which are often the most common side effects of the condition. Although the study by Bird showed some improvement in the subject's social skills, it was only a single case study, and there was no evidence that this would carry over to a larger population or a different age group. Additionally, in the article Treatments for Autism, Parental Choices and Perceptions of Change by Bowker et al., the authors surveyed 970 parents of children with autism and other pervasive developmental disorders about their use of treatments with their children. Of the treatment, medication had the highest rate of discontinuation. On the other hand, in the same article, ABA was reported to be the most widely used treatment among the survey results, and all reviews of ABA were high, whereas the reviews of medication were mixed.
Bowker et al. Used this chart to detail the results of their study. Medication was the most frequently discontinued treatment option at a rate of 19.9%, or 281 people surveyed. This was most commonly due to the lack of behavioral progress, or an aversive result of the medication. There were no reports of medical procedures being used to treat symptoms. Of the treatments parents reported using, ABA was the most widely used. 37% of participants used ABA. Medication was only reported to be used by 14.6% of parents surveyed. Jesse will now conclude the pros discussion of the medical model.
To sum up the medical model, medication can be used to decrease symptoms of comorbid disorders when other therapies are not working. Medication can be easy to use, is convenient, and can show improvement quickly. It has been shown to improve social skills, increase focus level, and reduce impulsivity, among other characteristics that are known to be common in ASD. However, there are a number of cons related to this method of treatment. Medication can come with a variety of side effects, anywhere from mild to debilitating. Additionally, medical treatments can be easily discontinued by parents or individuals taking the medication. And now we will begin to discuss the pro side of sensory integration, starting with Angela providing a summary of the topic.
Sensory integration therapy has been widely used and accepted by both parents and occupational therapists as an effective treatment for children with autism spectrum disorder. This therapy, practiced by occupational therapists, uses play activities in ways designed to change how the brain reacts to touch, sound, sight, and movement. This is often found to increase daily function. Sensory hypothesizes that demodulating sensory information can result in sensory defensiveness and under or over responsiveness to sensory stimuli, which may present itself in a client as developmental, learning, or behavioral problems. Many occupational therapists choose sensory integration therapy, often a sensory diet, as a clinical treatment designed to help individuals process the sensory input received from their environment appropriately. In a survey of occupational therapists, 82% stated that they always use the sensory integrative approach for children with ASD. 6% of parents stated that they had their child exposed to sensory integration therapy. Practitioners report three types of benefits from sensory integration therapy. They are enhanced ability to focus on materials, reduce challenging behaviors such as self-imposed behaviors, and improved nervous functioning, resulting in improved language and movement. And now Katie will provide some of the research behind sensory integration.
The article Occupational Therapy Using a Sensory Integrative Approach for Children with Developmental Disabilities by Schaaf and Miller details the history of sensory integration. It was originally developed for children with learning disabilities by an occupational therapist, Jean Ayers, who believed that difficulty learning reflected a problem with neural functions, which for some children could be solved with help processing sensory information that they receive. Sensory integration activities aim to incorporate sensory, motor, cognitive, and perceptual skills. It has been noted that children with autism may be able to improve their play, academics, and social skills through the use of sensory integration. Since its development, sensory integration has been divided into three groups: sensory modulation disorder, sensory discrimination disorder, and sensory-based motor diets. Each of these groups can be addressed through different techniques in sensory integration therapy. As of 2005, over 80 studies have been done to assess the sensory integration model, and about half show some effectiveness of the treatment. Although not enough research has been done to find a definite conclusion about the effectiveness of sensory integration, the authors believe that the field has tremendous promise. The article Comparison of Behavioral Interventions in Sensory Integration Therapy in the Treatment of Challenging Behaviors by Delvin et al. Compared the use of sensory integration treatment versus function-based behavioral treatments in addressing aggressive and self-injurious behaviors. There were 4 male participants, all under the age of 12, who were diagnosed with autism spectrum disorder, which was accompanied by these challenging behaviors. Baseline data was taken, and then an alternating treatment design was implemented with each of the boys for 10 days. The sensory integration therapy used materials such as a vestibular swing, trampoline, peanut-shaped ball, being wrapped in a blanket, deep pressure, tapping the body, chewing on a chewy tube, and/or joint compression. Behavioral interventions were developed individually for each of the boys based on the function of their behavior. In 2 out of the 4 patients, sensory integration therapy decreased the rate of aggression from baseline.
This chart is from the comparison of behavioral intervention and sensory integration therapy in the treatment of challenging behavior by Delvin et al., which compared the use of sensory integration treatment versus the function-based behavioral interventions in addressing aggressive and self-injurious behavior. The chart shows participants 2 and 4 had decreased rates of self-injurious behavior after sensory integration when compared to baseline. Sensory integration therapy was effective for these 2 participants. Mandy will now begin to explain the con side to this form of treatment and why ABA is a better choice.
We have a responsibility to recommend effective treatments based on empirical evidence. Current research on sensory integration effectiveness is inconclusive because many studies are not well designed. And the studies that are well designed show sensory integration therapy did not benefit the individuals receiving the treatment. In addition to the lack of empirical studies to show the effectiveness of sensory integration, there have been studies that compare sensory integration treatment to behavioral treatments in which sensory integration treatment was not effective, but behavioral treatments based on functional assessment have been proven to be effective. Here is Katie with the research behind the cons of the sensory integration.
Delvin et al. Discussed the results of their comparison of sensory integration versus function-based behavioral interventions, which had mixed results. Behavioral interventions were more successful than sensory integration in reducing aggressive behaviors, which according to Delvin et al. Is consistent with previous research. The limitations of this study included the alternating treatment design, which could have interfered with the success of sensory integration therapy, although the authors did not feel this was a real concern. Additionally, it was recommended that further studies be done using more participants to compare both types of treatments. Technical difficulties.
For participant 1, sensory integration actually increased the average aggressive incidents per day to a rate higher than baseline. For that same participant, aggressive behaviors decreased on days where the behavioral intervention was used. For participant 3, there was no difference in the rate of aggression between baseline and sensory integration, so the treatment had no effect. It is important to note that for all participants, aggression was reported at a lower rate on days when the behavioral intervention was used as opposed to sensory integration was used. In fact, the behavioral intervention reduced the rate of aggression to 0 for one of the participants and near 0 for the other 3.
Another article, A Comparison of Sensory Integrative and Behavioral Therapies as a Treatment for Pediatric Feeding Disorders by Addison et al., also compares the 2 therapies. The study had 2 participants, a 1-year-old boy and a 3-year-old girl, both of whom were admitted to a pediatric feeding disorders day treatment program due to sensory issues with food consumption. An occupational therapist was brought in to design a sensory integration treatment to use with each of the participants, and a behavioral intervention related to the function of escape was also developed. The results of the study showed that sensory integration was not successful in increasing the amount of food the children tolerated, and it also did not successfully decrease inappropriate eating behaviors. The behavioral intervention related to escape was successful in increasing appropriate eating behaviors. One limitation to the study was that non-contingent reinforcement was also available in the behavioral intervention, but not in the sensory integration. Sensory integration may have been made more effective with the combination of non-contingent reinforcement, but that would not have isolated sensory integration as the only intervention being used. Further research should be conducted. However, this study concluded that sensory integration was not an effective treatment for feeding issues.
Charts from a comparison of sensory integrative behavioral therapies as a treatment for pediatric feeding disorders by Addison, Piazza, Patel, Bachmeyer, Milnes, and Otto clearly show behavioral interventions to be more effective than sensory integration in this case. The charts on the top left and top right show the percentage of bites accepted by participants. The first participant had near 0% of bites food accepted, while the second participant had a variable percentage of bites accepted in both the baseline and sensory integration treatment phases. In the behavioral intervention phase, which was escape extinction plus non-contingent reinforcement, both participants had nearly 100% of bites accepted. When sensory integration therapy was implemented once again, both participants' percentages decreased, and when the final best treatment phase of behavioral intervention was implemented, both participants' percentages of bites accepted were nearly 100%. Both participants also had a significant decrease in inappropriate behavior per minute during the behavioral intervention, as shown in the bottom two graphs. Jessie?
To review, sensory integration therapy has been widely used and accepted by both parents and occupational therapists as an effective treatment for children with ASD. Many occupational therapists choose sensory integration therapy or a sensory diet as a clinical treatment designed to help individuals process the sensory input received from their environment appropriately. The three types of benefit from sensory integration therapy are enhanced ability to focus on materials, reduce challenging behaviors, and improve nervous system functioning, resulting in improved language and reading. However, current research on sensory integration effectiveness is inconclusive because many studies are not well designed, and studies that were well designed show that sensory integration therapy did not benefit the individuals receiving treatment. In addition to the lack of empirical studies to show the effectiveness of sensory integration, there have been studies that compare sensory integration treatment to behavioral treatments, in which sensory integration treatment was not effective, but behavioral treatments using functional assessments have proven to be effective. And now, Mandy will tie things up for us.
ABA is considered to be the gold standard treatment for individuals with autism spectrum disorder in most of North America. Not only has ABA been proven to show functional improvements that last in individuals with ASDs by researchers, it is also used by most clients and also had high reviews in comparison to medical alternatives as indicated by the study Treatments for Autism, Parental Choices and Perceptions of Change. It has been proven to bring about lasting improvements through empirical evidence. Some occupational therapists, parents, teachers, and others favor alternative approaches such as the ones we have discussed today. ABA is the better choice when compared to sensory integration based on the fact that the studies lack empirical evidence and are not well designed. As behavioral analysts, it's our duty to provide our clients with effective and scientifically supported treatment. Any other kind of treatment would violate the Compliance Code 2.09, which states that behavior analysts have the obligation to provide clients with and teach them about the most effective treatment that is scientifically supported. When all the facts about each treatment are studied, ABA is the only one that has empirical evidence and reviews from parents of children with ASDs backing it up. And now we'll hear from Adrienne, who will answer questions.
Adrienne, we actually can't hear you.
It's It's still muted. I can't unmute for you. Click the microphone at the top of your screen.
Okay, and then we'll start back from the beginning of our question.
What does the research say about the genetic factors related to people with autism? How does this support the medical model? There have been studies done to see if there are genetic factors related to people with autism. One study was conducted by Fraser et al. In 2014. This particular study looked at genetic and shared environmental contributions when looking at autism symptoms. The study compared twins with ASD to twins who did not have ASD. The particular study had 4 major findings behind it. The first finding is that extreme levels of quantitatively measured autism symptoms were heritable, but with no significant shared environment. Another finding was that there was lower heritability with less extreme autism symptoms. A third finding was the social communication interaction and restricted repetitive behavior showed high genetic correlations, meaning these were driven by a common genetic source. The last finding was that liability threshold model estimates of additive genetic tend to be much lower. There are also studies done that show genetic relations between autism spectrum disorder and attention deficit hyperactivity disorder. According to Stein et al. 2012, these two disorders share between 50 through 72% of their genetic factors. Stein conducted a study with 121 families that had both autism and ADHD. Those who participated included a parent, a child with ADHD, Asperger's, or PDD-NOS, and then at least one sibling. The child, as well as the parent, were screened for ASD and ADHD. This study found not relation between maternal and paternal ASD and ADHD. So parents having ADHD is predictive of their children having ASD, but not the other way around. However, there is more research needed to clear this up. All this relates to the medical model because they're looking at the symptoms of autism and trying to relate it to genetics so that they can find ways to treat it. They're trying to prove that it is a medical condition that can be treated or prevented with medication or genetic testing. Question 2, what are some biomedical factors that relate to the medical model debate? There are various medical therapies that base their theories that some people with ASD have their intestinal barrier compromised and therefore abnormally permeable. This suggests that digestion of natural foods, such as anything containing gluten or casein, are able to enter the blood and induce antigenic responses that can directly affect the central nervous system. There was a randomized, double-blind, placebo-controlled trial conducted by Monosinghi et al. To examine the effects of a digestive enzyme supplement to assist with this biological trait these subjects with ASD had. The supplement was shown to improve expressive language behavior as well as other symptoms. Outcome measurement tools included global behavior rating scales, additional rating scales of other symptoms by parents and therapists, and monthly completion of the Rescola Language Development Survey. The types of prescription medication used, which is at least 3 months prior to the study entry and continued during the study, were methylphenidate, clonidine, sodium valproate, risperidone, Valergan, Polyramine, Intal, Ventolin, Fixotide, topical corticosteroid cream, iron supplements, and laxative agents. Special diets that were used by families included gluten and casein-free, gluten-free, organic foods, egg-free, and low-sugar diet. This trial concluded that treatment with enzyme was not associated with significant improvement in behavior, food variety, gastrointestinal symptoms, sleep quality, engagement with therapists, or the language development survey vocabulary, or sentence complexity scores. In contrast, only a small improvement was seen with food selection. Biomedical factors that relate to the medical model would include the systematic approach to treat underlying issues of autism inside the body. The treatments are managed by a physician and treat ailments of the body, whereas the use of medication treats symptoms that are associated with autism and comorbid conditions. Third question is, how do dimensions of ABA influence the debate? The 7 dimensions of ABA greatly affect the arguments used throughout the debate. There were 3 that we felt most influenced this debate, beginning with effective. The entire underlying theme of our debate revolves around the effectiveness of treatments, and it is important to note that throughout the research used, ABA has been the most consistently effective treatment for individuals with autism spectrum disorder. The medical model and sensory integration therapy both have mixed reviews from the research, while ABA proves to be effective across various studies. Additionally, generality was a huge factor when considering our pros and cons for this debate. Medication and medical treatments need consistency of use over time, and sensory integration therapy must also be actively used to be effective. Once either of these forms of treatment are discontinued, the positive results seen from their use may decrease or disappear altogether. However, the goal of ABA therapy is for the techniques to generalize across settings, people, situations, so that therapy may eventually be discontinued. If done correctly, the positive outcomes from using ABA therapy should be able to continue without lifelong use of the treatments. Another dimension that influenced this debate is behavioral. ABA therapy is directly related to behavior, while medication and sensory integration typically deal with brain function or internal responses that led to external behaviors. ABA therapy targets behaviors that can be observed and measured with the interventions that can be analyzed. Medication and sensory integration are not as easily observed or behavioral as ABA therapy, making it a better choice. That will conclude our debate on alternative models to address quality care for children with autism spectrum disorder. Thanks for watching.